Bismillah. Let's talk about Dermatofibroma DF. So, as you can see, Dermatofibroma looks like a solitary nodule that can occur on the skin. It's a dermal lesion, as the name suggests. Dermatofibroma, it's a fibrous lesion. Oma means that it's a benign tumor. It's usually a firm, round, papular, small small lesion. Sometimes it can be nodules, more than one, and it's most commonly on the lower limbs. Then the next common is upper limbs, and the next common is on the trunk. As I said, it can be multiple, but those ones that are multiple are usually related to systemic lupus erythematosus or HIV, Down syndrome, or myasthenia gravis. So other syndromes that can come with this multiple dermatofibromas. The reoccurrence of it is 2%, so it's very low. Once you remove the tumor, okay, even if it's partial, once you remove it, if it's like this, if it's, they do an ellipse, skin ellipse, so if it's like this or like that, whatever form that they remove it, even if some of it is still there, it usually never occurs again, except in those minorities. Now, there are variants of it that can reoccur in the amount of up to 30%. Okay, let's look at it. That's the variants, cellular dermatofibroma. Before that, there is a debate about dermatofibroma being a neoplastic versus a reactive reparative process change. And that debate has its own papers and everything, but just to know that they are still debating about this. All right, so let's look at it, the microscopic features. So I've got one case here, and as you can see, this is the ellipse. So let me do a better ellipse. Okay, so the tips, these ones are basically what's in here. So the tips in here are very free, so they are free on the margins in there. Not all margins were free, however, as you can see, this is the dermal tumor. This is not a normal looking dermis, all right? And so it is specifically in the dermis. It has something that they call a lens shape that has its long axis parallel to the epidermis, but it's not a defining feature. Anyway, it is relatively circumscribed, and the lens shape you can see on low power. Sometimes it's really difficult to tell, but you can see short fascicles or storiform areas. So the short fascicles, as you can see here, okay, so short fascicles, you see how these are fascicles that are very short, and we are on a high power in here. Sometimes we have this storiform pattern. Okay, just to illustrate verbally and physically what it looks like, storiform pattern, you can imagine that it's like a cartwheel. This is your cartwheel, and you have your storiform pattern like this. You can say clock face, but it doesn't really make much sense. There is another thing that they say it's like a fabric, a fabric of a mat like this. They say that it resembles that, so that's what storia form. It's the shape of the storia or straw. Doesn't really matter, but that's what a storiform pattern refers to. So either short fascicles or storiform pattern, which really is so difficult to observe in here. Let's look at this image. Okay, so you see it is really difficult to understand it. Okay, that's on low power. So let's go on a higher definition and we'll see that it's not in this case, at least not in my case here. And so you see in here, you cannot really give a definite what does this look like. I do not really see any short fascicles. The problem is it's mostly epithelioid cells, and we've got this one as well. If you want to compare it, it's all the same. Doesn't look like there is any fascicular or a storiform pattern here. Alright, so typically it would look like something like this or like that, with these spindle cells going into a specific pattern. Now, there is another thing that is typical, and I can see it in my case, which is collagen entrapment. Collagen entrapment is basically where we have these histiocytes, these cells include dendrocytes, but mostly fibroblasts and epithelioid cells or histiocyte-looking cells. Alright? So collagen entrapment, as you can see from this image in here, you can see this is collagen and it's getting trapped. This is better in here looking. Alright, this one looks also like entrapment of collagen fibers. You see how these cells are in here and they're just trapping it. Here is a zoom in for you. Alright, so that's it basically. Collagen getting trapped in the peripheries specifically. So if you look at the peripheries of this tumor, you're going to see this, typically. And what I think is that the pattern, there are other 2 or 3 patterns that can be there, but this one looks like haphazard or patternless pattern. Another thing is Grenz zone. Grenz zone is the sparing of the superficial papillary dermis. You know how we have the dermis, 2 layers. I mean, the dermis has 2 portions, okay? The papillary dermis, which has the loose connective tissue, and then the larger dermal area, which is the reticular dermis. It has more blood vessels, it has more vascular, lymphatics and everything, and nerve bundles and everything, okay? But this one, the dermal papillary area, okay, it has papillary projections intersecting with the epidermal reed ridges or papillary projections of the epidermis, basically, because it's just trying to supply it. However, in here, you can see that the dermal papillae is spared, so the lesion is mostly in the reticular dermis. There is another thing you can see we'll talk about. So there is a flattening of this area. Just remember this. It's not like there is papillae, there is flattening. But it doesn't look so well in here because this is a papillae, this is another papillae. But you can see that it's sort of flattened. Okay, here it's not as much flattened. Here it's a little bit flattening. Why is that? This is because it's called reactive changes, and reactive changes include the acanthosis, and acanthosis is basically your stratum spinosum, your middle upper layer is going through hyperplasia. Okay, hyperplasia of this layer will make you have a thicker area in here. It's better to see it on this image. You see, this is the basal layer, this is the spinosal layer, and this is your granulosal layer, and this is your corneum layer. This one expands. and as it expands, it flattens this area. Acanthosis. Another thing, if you can notice it in here, there is a lot of pigment in here, and there is sometimes hyperplasia of this layer, which is the basal layer. All right, so the basal layer sometimes goes through hyperplasia, okay, and it can have hyperpigmentation. Now this is part of the induction phenomenon, and induction phenomenon means exactly what I've mentioned: hyperpigmentation, too much pigment in the basal layer, and basal cell hyperplasia. The problem with that is that it resembles basal cell carcinoma, BCC. There is another two things that can happen, which is called follicular and sebaceous induction, and that is just hyperplasia, or not just hyperplasia, but those cells in the follicle, those cells surrounding the follicle, the hair follicle, the hair follicle and the sebaceous gland, they go into a basaloid transformation resembling again BCC. It's not as important as your microscopic features in here. The most important is a Grenz zone, collagen entrapment, and your cells are fibroblasts and histiocytic looking cells, or histiocytoid cells. You can say epithelioid cells. That's what it's best to say. Okay, lens shape is not as important. Relatively circumscribed is important, but definitely difficult to see. Actually, this one is actually good. Okay, relatively circumscribed, dermal, short fascicles or storiform if you've got it. If you don't, collagen entrapment and the Grenz zone with the sparing of the papillary dermis. Okay, if you get anything, that's all about the video. Variants are a lot and they are not very high yield, but it's nice just to throw them in. There is the deep dermatofibroma. It lacks epidermal changes because it's deep, so it doesn't affect the epidermis as much. Foamy macrophages with lipidized dermatofibroma. You can imagine that there is lipid. Foamy macrophages, hemorrhages, totem-like giant cells, and totem-like giant cells means multinucleated giant cells with nuclei arranged around the central cytoplasm. So these are your totem cells. You have multinucleated giant cells with your nuclei on the edges and your cytoplasm in the middle. Again, same thing. I'm probably wrong, I'm not really sure, because there looks to be like a cytoplasm around them, so they could be in the middle and the cytoplasm is the periphery. But it looks like this. That's how you remember it when you look at it, basically. Alright, hemosidrotic DF has abundant hemosiderin. Aneurysmal DF is the lipidized one that we already saw in there with the totem-like cells, giant cells, and there is another thing which is large blood vessels with filled-in spaces. Large blood vessels filled with blood, large vessels or large spaces filled with blood. In any case, monster cells, they have bizarre large hyperchromatic nuclei. However, it is benign. Okay, benign. So it's not malignant, it's benign. I know that word confused me as well in the beginning. Epithelioid histiocytoma, epithelioid cell histiocytoma. It lacks the entrapment, has a collarette of epidermis at the periphery, mucinous cells, cytophagocytosis, cells eating cells, ALK overexpression. Alright, That's about it. And here is my references. For immunohistochemistry, you want to make sure that you remove the other differentials. Okay, factor 13A is very specific for dermatofibroma. However, I think it can be in another disease, I don't remember its name, but it doesn't resemble it as much. So your H and E is where you take your decisions, really, your suspicions. This one is very important, CD34, it's negative. However, in the variants of dermatofibroma, and sometimes CD34 can be positive on the peripheries, it can be positive in other areas, but in DFSP, it's diffusely positive, taking all of the lesion really well. That's what you want to remember. S100 differentiates neurofibroma and melanocytic lesions. MSA and Desmond make sure that it is not a muscular leiomyoma. You know, it's a differential diagnosis as well. Usually we just really do these three if I know correctly, all right? And here's my references. I took this from Pathology Outlines and Dermatofibroma, Mills and Sternberg Diagnostics Surgical Pathology, the 7th edition, if you want to take those and go with your day. Another one, I think I took some information from Washington Manual, the 3rd edition of surgical pathology. And hopefully this was really helpful. Thank you for listening. You take care now. Bye.